Hi guys, this is Charles. I'm one of the surgeons at the Animal Emergency Centre in Melbourne, Australia. This is Lucky, the same dog that we were doing the pyometra on, or what probably is endometritis. The reason why the dog came in originally was because it had this mass on the rostral end of the mandible. So we were doing a rostral mandibulectomy. We offered a pre-surgical biopsy on this dog, but the owners have elected to just remove it because it is ulcerated and bleeding, and the dog really is not going to live very long if we don't take this thing out. And so they didn't really care what it was, as long as we were able to remove it. If you haven't already done so, please subscribe to our channel and make sure you turn on notifications so you get a ding on your phone the next time we live stream. So I'm just doing my skin margins here, trying to leave a little bit of skin to close around the front of the mandible. I'll try to keep my head out of the way as much as I can, but can't promise you anything. So as we've discussed previously, when you have mandibular masses or oral masses in dogs, is this turned on already? The suction? It looks like it's on.
Yeah, that one need a paddle to activate, I think.
When you have oral tumors in the bone of, or that's invading the bone in dog mouths, we think about the mnemonic, which is foams at the mouth. And so that's fibrosarcoma, osteosarcoma, melanoma, squamous cell carcinoma, and yeah, fibrosarcoma. Okay. So not sure it's doing much. It's not plugged into the front of the machine. So fibrosarcoma, osteosarcoma, acanthomatous ameloblastoma, melanoma, and squamous cell carcinoma. And they have very different behavior depending on histological type. But again, the owners weren't really interested. Can you pass that over to Cindy? And knowing what it was before we took it out. So we did go ahead and take chest x-rays to make sure it wasn't gross evidence of metastasis. All right, so I've got this special suction unit to evacuate our smoke, which I don't use very often, but I probably should. It seems to work really well. I think I'm going to try to move my camera a little bit so my head... Was my head getting in the way? Just move it back this way and then forward and that way. Hopefully that'll keep my head out of the way a bit. Can I get my Gelpies, please? And I don't want to get too close to the bone because there is potential to have incomplete surgical margins. Grab some scissors, please. Make some, and thumb force it, please. This is fine, yeah. All right, so I'm cutting through the gingiva here. And I'm going to come around caudally along that lateral margin. Now I'm trying to undermine a little bit. Just seeing what the dentition looks like there. That's my glossus muscle there. All right, so now I'm just palpating how far caudal the mass goes on this side. And Emma, just let me know if my head's in the way of the camera.
You're good.
Thank you. I'm going to switch sides with you, please, Cindy. So regarding surgically prepping the inside of the mouth, we don't really do much. It's virtually impossible to sterilize. So that's mental nerve right there, and we are going to do a nerve block. Just trying to palpate there and see how far back this goes caudally.
Yeah, we might have need to move the paddle for the suction to this side of you.
There's a question about how I determine my surgical margins if I don't know the tumor type. I'm assuming that it's the worst case scenario, which is a fibrosarcoma, and so I'm going to take margins that would be appropriate for a fibrosarcoma. Can I please get another Gelpy? Margins are going to be similar for all of these tumor types. Fibrosarcomas probably are a little bit more aggressive locally than the other tumor types. But if you assume the worst case scenario and cut for that, you'll probably be okay if it turns out to be something else. And I am going a little bit wider on this side than on the other side. Now my mandibular vessel is going to be right up here,
Wow.
quite far ventral. All right, can I get some Homans, please, and my saw? All right, so now I'm kind of going to poke around here. I'll cut this one first because this one's farther rostral, and so it's very possible that the blood supply won't be as developed on that side. And I think I should be behind the root of the canine tooth, which will make it a little bit easier. So that's that is the isolated mandibular shaft right there. Question about whether this dog will have to be on a feeding tube for the rest of his life. He will not. Often these guys are eating within a couple of days of surgery. We are putting in a feeding tube just in case, but it's usually not necessary. More than a week out from surgery, and the owners are prepared for that. The other nice thing about the feeding tube is that you can give them their medications as well. Can we get our saw blade, please? And we'll need some saline as well. Yep. So I'm just getting the saw together. And I'll get my osteotome and mallet when you get a chance as well. All right, so the mandibular artery is quite far ventral, so I'm going to cut dorsally first. What's that? I'll do it after. I'll do it right down the mandibular, canal.
That's pretty gnarly.
Yeah. Okay, so let's get some saline going here. We'll get some suction going as well. Or let's get the Yankauer tip on, please. And then we'll just have the suction dorsally here. Here we'll get, just down there, we'll get Emma to hold on to that. So I'm going to stay dorsal with my cut. So I'm trying to avoid that mandibular artery. Okay, so I've gone all the way through there. And then I'm going to cut partial thickness in the cortex all the way around. Okay, switch sides. So again, I'm trying to avoid that artery. Okay, that's pretty good. So see how I've cut all the way around, but I haven't cut the artery yet. And then I'll get my osteotome and mallet. And I'm going to try to split it again without getting that artery. So I'll just get you, Cindy, to give me some counter pressure there. Maybe with your finger. Yeah, I'll try not to cut your hand. Okay, so see how I've been able to split that and that artery is still intact. So we've had 0 blood loss.
Amazing.
All right? So then I'll come in with my ligature. That's a trick that I kind of developed when I started doing these. I was like, I don't know why we have to lose so much blood. So now I just ligashore that vessel, and we've had 0 blood loss. All right? All right, so I'll just pack this off in here. Can we get some bupivacaine, please? All right, so I'll just pack that off, come around the other side. Just get my cautery. All right, and then I'll isolate that mandible there. Just make sure I'm happy that I'm caudal to the tumor. I feel like I'm going to have to go all the way back here. All right, so then I'll come in with my saw again. Question about how much of the mandible you can take out. I've actually done complete mandibulectomy, both sides on a dog before, and it was still able to eat. So you can actually take out quite a bit. All right, come around. So cut a little bit more here. And then come around the other side. Staying dorsal. Kind of coming through a tooth root there. So I'm all the way through there. All right. It is trying to wake up?
It's not. It's just
Hypertensive, okay. Okay, give you that. Give me some counter pressure. Okay, so that's broken there. Still no blood loss. Pull this out here, ligature our vessel. Bob's your uncle. All right, so now we just need to finish cutting out the soft tissue.
Is the heart rate higher than it has been? No.
Okay, so leaving the tongue there. That's how you do a mandibulectomy with zero blood loss. Okay, so that's what we've taken out there. All right, so we'll get rid of these guys.
That's amazing.
All right, so that's the mass right there. All right, pretty nasty. All right, I'll switch sides again. Sorry. All right, so how are we doing here? Good, just a couple of little bleeders. All right. So, that's the base of the tongue there, that's the mandible there, that's the other mandible there. All right, so can I get some 2O PDS? Oh, I've got some 2O PDS here already. Oh, I need some bupivacaine or just bupivacaine would be fine. All right, so then I need to go down into my mandibular canal, and then I'm just going to inject bupivacaine in there. And then same thing over here. And then just a little bit here. All right, and then let's get a longer piece of 2-PDS. I think one of the best things that I experienced to help me be able to answer questions as I'm doing things is that I had 3 boys. And so they were always asking me questions as I was doing stuff. As in 3 children. And they can ask a lot of questions.
Oh, I can imagine. Have you done mandibulectomies on cats?
Yeah, I don't like to. There's a question internally from Emma, our intern, about whether I'm happy to do mandibulectomies on cats. I certainly have done them, but the problem is that if you're doing a mandibulectomy on a cat, it's usually for a squamous cell carcinoma, and they have such a poor prognosis that I just think the survival is so short after a mandibulectomy that I question whether it's worthwhile.
So it's mainly palliative.
Mainly palliative, although there was one study by Sarah Boston, who's a surgical oncologist in Canada. I think she got like a year or a year and a half median survival time with mandibulectomies in cats, which I frankly was very surprised at. So I always thought maybe I should revisit it, but my experience has been that they don't do particularly well.
Squamous cells mainly locally invasive?
Squamous cells in cats, in dogs they're more locally invasive. In cats they're highly metastatic. Yeah, so cats, I think the median survival time is probably 2 months no matter what you do. So now I'm bringing that gingiva around the front of the mandible. And these are a little bit of a puzzle when you try to put them back together. You obviously have to get the mandible covered, and then you want mucosa to mucosa, and so it is kind of a work in progress as you work your way around the mandible.
There's a question, Michelle, why cut through the tongue? Wouldn't it help to keep it intact as well?
So I did not cut through the tongue. Now the tongue is still 100% intact. I just cut through the frenulum. And see how I'm burying all of my knots, because I don't want it to be irritating to have knots in the oral cavity. Let's switch sides with you now, please, Cindy. Can I get the table up a little bit? Yeah, if I got irritated getting asked questions during surgery, I would never have started live streaming. That's great, thank you. Do we get another towel clamp, please? Yes, I would not have started live streaming. I wouldn't have been a teacher, like I was a professor at Colorado State University, and probably wouldn't have had children. So no, there aren't any issues with removing the salivary papilla. Occasionally you will get a ranula underneath the tongue that can last a few weeks.
It's gonna feel so much better having that out.
Yeah. Can I get some, just check to see if I've got another piece of 2.0 PDS there. Can I get some more 2.0 PDS, please? All right, let's get that pulled back a little bit, please, so I can expose the mandible there. If we can lift that up a little bit. Yeah. That's great. So I'm suturing my sublingual mucosa to the gingiva on the medial or mesial aspect of the mandible.
Like a cancer case, if you do gingiva.
Yeah. Sometimes I'll drill a hole in the mandible to act as a suture anchor.
If you don't have too many tissues out.
If I don't have enough tissue yet. So gradually we're just making this hole smaller and smaller. So there's a question about whether leaving the tongue in is going to cause it to hang out. It does hang out for a little while, but then they learn to pull it back in. Yeah. Can I get some Gelpies, please? Just lift that up there for me. And the prognosis, people are asking what the prognosis is. It's actually, I mean, it depends totally on what the histological type is. If this is a squamous cell carcinoma, generally probably a couple of years. If it's a fibrosarcoma, then recurrence rate is actually quite high, and I would guess maybe 6 to 12 months. If it's osteosarcoma, the median survival time is about 21 months. If it's an epilus, then surgery should be curative. If it's melanoma, then the prognosis is pretty grim, with probably 50% of the dogs being dead within about 6 months. So now I'm just covering up the end of the mandible.
Your problem look like sharp bone, is it?
Not really. So it's all covered up with soft tissue. "12-year-old Chow Chow." That's correct. Somebody just asked if that was the case. Now we can see that two sides of the lip are kind of meeting in the middle. All right, so now we need to...
Do you like some pillows?
Yes, please.
Yes. There's no pillow to use.
So there's a question about melanomas. The cause of death is actually metastasis, usually. And so there are some newer treatments, immunotherapy for melanomas, which seem to be showing some promise in humans and in animals. There's another question, what resources to use for survival time? Probably the best one is the vsso.org, so Veterinary Society of Surgical Oncologists.org. They provide a lot of really good information, and it's free, about survival times with all different types of tumor. Regarding oral bacteria causing infection, it certainly is a problem, and these do probably get infected a bit more than other tumor types. That being said, I still usually don't put them on antibiotics prophylactically. I'm going to wait and see if they get infected, then I'm going to treat them appropriately. But I don't want to get resistance, and prophylactic antibiotics are not going to prevent infection in these cases. So I'd rather them get infected and then treat them appropriately rather than trying to prevent it.
We don't put them on antibiotics for dental.
I beg your
We
pardon?
don't even put them on antibiotics for dental.
Sorry.
We don't put them on.
Yeah.
Yeah.
So Emma, our intern, is just commenting that they don't use antibiotics for dentals. And I could see potentially, I guess, giving them IV antibiotics during the procedure if you were concerned about seeding, mitral valve or something like that. But afterwards, I would not personally put them on antibiotics. And definitely no drain in here. Like, a drain is going to increase your risk of infection. What time is it? 3:30. Yeah. Can we ask them to pre-med the Great Dane? And maybe if we have people available to go ahead and get started on that? That's great, thank you. I've got a lecture tonight at 7:15 from home, as in a webinar, so I'll have to be out of here. So there's a question: is veterinary care as expensive in Australia as it is in the US? I'd say it's probably about on par. It's just so expensive to run a veterinary practice. In my old practice, our wages, so our salaries alone, were about $7.5 million a year. And salaries accounted for about 70% of our revenue.
Is this normal, like the structure of the revenue like that, but 70%?
Yeah, you want your wages to be somewhere between 50 and 56, something like that. We were overstaffed. All right, do you want to finish this off for me, Cindy?
Oh,
All right, so you're just going to continue with intradermal, and then,
okay.
do you think you can do an intradermal in that?
Okay, sure.
Okay.
So this is intradermal.
Yeah, so I'll just go back and make sure there aren't any questions that I haven't answered. So I don't know about any physical therapy really for these guys, other than we usually do some soft food, usually in the form of like hand-rolled meatballs for a while. We also have the feeding tube in this dog, which will help. Just going back. pathology will take us about a week to a week and a half. Let's see. So the tongue hanging out, they can get dried out, but usually they learn how to pull it in. So the tongue is draped out of the field. Hi, Vinay from Mauritius. Hi, Mississippi, Costa Rica. All right, I think that's pretty much it. Postoperatively, because we've done our mandibular nerve block, he shouldn't be, or she shouldn't be too uncomfortable, although we did do the ovarian hysterectomy at the same time. So we will keep her on, is she on a CRI already? Yeah, we'll keep her on a fentanyl CRI overnight, and then give her meloxicam and paracetamol, and then start weaning her off tomorrow. I think we'll go ahead and put on a fentanyl patch as well. All right, and that's pretty much it. So if you haven't already done so, please subscribe to our channel. Make sure you turn on notifications. Let me just move this around the front a little bit and see if I can give you a little better idea of what it looks like. That's a little better. All right. Anyway, thanks a lot for watching, and we will see you again soon.